We are back with the next video in our series on shock. In our last video, we talked about the circulatory system in terms of systemic vascular resistance and cardiac output, and we talked about all the different components that affect cardiac output, like preload, contractility, and afterload. By the end of this video, you should be able to explain the pathophysiology of 4 different types of shock. You should also be able to discuss how you use fluids, blood products, and vasopressors to manage different types of shock, and you should have some way to treat shock empirically, even if you can't identify the type. The 4 different types of shock that we'll talk about are hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. And when we talk about shock, we're going to think tank, pipes, and pump. Let's talk more about each type of shock, and we'll start with hypovolemic shock. In hypovolemic shock, the tank is empty. There just isn't enough fluid or blood in the system. This is fundamentally a preload problem. If there's nothing in the tank, then the heart isn't filling up, and if the heart isn't filling up, there won't be anything coming out of it. All patients with shock look pale and sweaty, but a patient with hypovolemic shock usually looks dry and dehydrated. Like if you look at their face or in their mouth, you might notice that their lips and their mucous membranes look dry. And they usually present with some kind of history that describes a loss of fluid, like vomiting and diarrhea. You might alternatively hear about an injury or a trauma that could suggest blood loss. There are actually 2 different types of hypovolemic shock. The first is hemorrhagic shock, where what you've lost is mostly blood, and the second is non-hemorrhagic shock, where what you've lost is mostly water and salt. The distinction is important because if what you've lost is mostly water and salt, we can replace that with IV fluids. But if what you've lost is mostly blood, you should probably replace that with blood transfusions and actually limit the amount of IV fluids that you give. You've probably been taught that a sick patient should have a large bore IV, like an 18 gauge or a 16 gauge. But why do people care so much about this? Well, remember from your physics class like a million years ago when they taught you about Poiseuille's law and they showed you this ridiculous equation? You can forget all the details, but remember that flow through a pipe depends on radius to the 4th power. So the gauge of the IV, the radius of the pipe, can make a huge difference in how quickly you can infuse a bolus of fluids. With a 22 gauge IV, you can only infuse fluid at about 30 or 40 mils per minute. At that speed, it would take about a half an hour to infuse a liter of fluid. A 20 gauge cannula is better, and it gives you about 60 mils per minute. But if you have an 18 gauge IV, you can get almost 100 mils per minute. And with a 16, you can get over 180. A 14 gauge is the best with almost 250 mils per minute. Now we're talking about infusing a liter in like 4 or 5 minutes. Now, a 14 or a 16 gauge IV is pretty gigantic and they're not that easy to get in. So if you're stuck with a smaller IV, like a 20 or a 22, you'll want to push your fluids in under pressure. There are a lot of different ways to do this. High-tech devices where you place a bag of fluid inside a pressurized chamber, and there are low-tech devices that just look kind of like a blood pressure cuff. But you really just need to squeeze the bag somehow, and you can do that easily enough with your hands. Pressure can increase your infusion rates a lot. In one study, Reddick and his colleagues measured IV infusion rates with and without pressure, and they could often double the infusion rate that was listed on the package. A 22 gauge IV improved from about 36 mils per minute to 71 mils per minute. A 20 gauge IV went from 64 to 105. An 18 gauge went from 98 to 153. A 16 gauge went from 154 to 334. And a 14 gauge went from 236 to 384. So under pressure, even a 20 gauge IV can get about 100 mils per minute. And if you have an 18 gauge, you can get about 150 mils per minute. With rates like that, you should be able to infuse a liter of fluid in 10 minutes or less. Oh, and if you're trying to give fluids quickly, these electronic pumps are not your friend. The numbers displayed on these things are in mils per hour, not mils per minute. So if you set the pump to 999, which is as fast as this thing can go, it'll take an hour to infuse a liter of fluids. That is way too slow for someone in shock. Our next issue is how much fluid to give. And that's actually a bit of a tough one because it kind of depends on the case. We usually give fluids in boluses of 500 mils or 1 liter, and we usually try to give enough to fill the tank, but not more than that. I know that's kind of vague, and it's probably just easier to explain it with an example. Let's say you have a patient in hypovolemic shock. Empty tank, they have all the signs. Their mouth looks dry, they're pale, their cap refill is poor, and the monitor shows tachycardia with hypotension. You want to fill the tank, so you give them a 500 ml bolus. After that goes through, you reassess them, looking at their mucous membranes, their cap refill, and all those numbers on the monitor. After one bolus, not much has changed. So you give a second 500 ml bolus for a total of 1 liter. This time, when you reassess them, their blood pressure comes up a bit and their cap refill seems a bit better. They're still tachycardic, their mouth still looks dry, so you give them another 500 mils. Now, after 1.5 liters of fluid, their heart rate is coming down, their color looks better, and maybe now there's some urine in the catheter bag. This patient looks better and feels better, so you can probably stop there. But let's say you got excited and you pushed in another liter, or 2, or 3. Now your patient's complaining of shortness of breath, and you can see their oxygen saturations are going down. So you listen with your stethoscope, and you can hear crackles in their lungs. Now you've given too much fluid, and the patient has pulmonary edema. If this happens, don't panic. It's usually not a disaster. If the blood pressure is doing okay, you can probably just diurese them and take the fluid off over the next couple of hours. Now, this might seem like an overly simplified approach, but it really is how most of us do it. You just give a bit of fluid, reassess, give a bit more, reassess, and you keep going like that until you think the tank is full. You might give 500 mils and stop, or you might give 4 liters and then stop. Each time you reassess, look for those common signs of shock: pallor, cap refill, hypotension, tachycardia, level of consciousness, and of course, keep an eye on their lungs and their oxygen levels, because pulmonary edema would suggest that you've gone too far. Finally, let's talk about the 2 moments when you should not give fluids. The first we've already mentioned, and that's pulmonary edema. Obviously, if somebody has so much fluid in their body that it's starting to build up on their lungs, we don't want to give them more because we probably make them worse. The second situation is bleeding. Remember that hypovolemic shock can be hemorrhagic or non-hemorrhagic, and in hemorrhagic shock, you'll want to fill the tank with blood products, not IV fluids. That's because IV fluids can actually make hemorrhagic shock worse. The mechanism is a bit complicated, but you can think of this as mostly a dilutional problem. In fact, you've probably already seen something like this in patients admitted to the hospital. On their first day, they come in with a hemoglobin of 120. And then for one reason or another, they get a few liters of saline, and now their hemoglobin is 100. That happens because we've diluted their blood with all of the fluid. Now, let's imagine that same phenomena in a patient who's bleeding to death. Let's say their hemoglobin is 50. We give them 2 or 3 liters of fluid, and now their hemoglobin is, 30? So if a patient's shock is caused by bleeding, you want to limit the fluids you give and really just transfuse blood. And sometimes you'll transfuse a lot of blood, like more than you're used to. You've probably been taught to order packed red cells 1 unit at a time, which is correct in the vast majority of patients. But if a patient has bled so much that they're hypotensive, you're going to need a lot more than 1 or 2 units to stabilize that blood pressure. So if the blood pressure is low, order at least 4 units of O negative, or O positive for men. Worry about the cross-match later. Okay, that's enough about hypovolemic shock and bleeding. If the tank is empty, we fill the tank. The second type of shock that we should consider is distributive shock. Distributive shock is a problem with the pipes. The pipes are dilated and relaxed. Systemic vascular resistance is too low, and oxygen can't diffuse from the blood into the tissues. You'll note that this is also a preload problem. The tank is suddenly much bigger, but the amount of fluid circulating through it hasn't changed. So the tank is relatively empty. And if the tank is empty, the heart is empty. So preload is down, contractility is down, and then the blood pressure is down. The most common cause for distributive shock is sepsis. So patients will often have signs of an infection, like a cough or a fever from a pneumonia, or maybe they'll report dysuria from a UTI. Don't forget to feel the abdomen for tenderness, because maybe this is appendicitis or cholecystitis. And don't forget to look at the skin for signs of cellulitis. Also remember that anaphylaxis is a common cause of distributive shock. So if you see an odd rash or swelling, you'll want to ask about allergies. We treat this type of shock with some combination of fluids to increase preload and vasopressors to increase systemic vascular resistance. Most of the time, we fill the tanks first and then fix the pipes. If fluids are going to help distributive shock, you'll usually see some kind of improvement before you reach 30 cc's per kg of ideal body weight, which is usually around 2 liters in someone of average height. So if you're crossing over that 2-liter mark and the blood pressure is still running low, you probably need to jump ship and get some vasopressors going. In general, these drugs can do 2 different things to help out in shock. They can provide alpha stimulation to constrict the blood vessels and increase systemic vascular resistance, or they can provide beta stimulation to increase heart rate and increase contractility. Strictly speaking, a drug with an alpha effect is called a vasopressor, and a drug with a beta effect is called an inotrope, but most of the drugs we'll use do a little bit of both, so you'll probably hear most people just call everything a vasopressor. There are 2 vasopressors that I want you to know well: epinephrine and norepinephrine. Epinephrine is a drug you know from ACLS, and you may have already given it or seen it given to a patient with anaphylaxis. This is a drug with a mixture of alpha and beta effects, but more beta effects than anything else. You can use it in just about any kind of shock, but it's probably best reserved for those cases where you want to give an extra boost to the heart. For example, if you have a patient in shock from bradycardia, where the cardiac output is low only because the heart just isn't beating fast enough, epinephrine is the drug you'd want to reach for. It's also the drug of choice in anaphylaxis because it can give an extra boost to the lungs too. Now, all that beta stimulation does come with side effects. If you overstimulate the heart, you can run into problems with arrhythmias like AFib and VTAC and that sort of thing. So if the blood pressure is running low, but the heart seems to be doing okay, then what you really need is norepinephrine. Norepinephrine also has a mixture of alpha and beta effects, but it's much more alpha. It usually doesn't make the heart pump along any faster. Its main effect is shrinking down those pipes and increasing systemic vascular resistance. Both epinephrine and norepinephrine are usually given as an infusion that trickles in slowly over time. The dose is somewhere between 2 and 20 micrograms per minute, and just like with IV fluids, you kind of just give the patient as much as you think they need. Let's look at an example. We usually target a MAP of 65, and you'll remember MAP is that number in brackets next to the usual blood pressure numbers. Let's say your patient has a blood pressure of about 60/40, which would give a MAP somewhere in the mid-40s. You've been giving fluid boluses, 500 mils, then another 500, and another, and another. We've just hit that 2-liter mark and nothing's really changed. That blood pressure still looks terrible. So we start norepinephrine at, say, 5 mics per minute. After a minute or 2 to circulate, the blood pressure comes up a bit to 70/50, and the MAP is in the mid-50s. That's better, but we're not yet at a MAP of 65, so we increase the infusion up to about 10 mics per minute. After a few minutes to circulate, we cycle the blood pressure, and now we're at 90/60 with a MAP right around 65 or 70. Perfect. Now, you might look at that and think 90/60 doesn't sound like a great blood pressure, but it's okay so long as the MAP is around 65. Shooting for a MAP much higher than that probably doesn't get you any benefits, and it probably increases the risk of side effects. Like, if we cranked that norepinephrine infusion up to 15 or 20 mics, our patient would probably just get hypertensive, and what good is that going to do? And if you let that higher dose run for hours and hours, that little bit of beta stimulation that comes along with norepinephrine will eventually catch up with you, maybe causing a run of AFib or some other arrhythmia. Most vasopressors are very short-acting, so if you do see the MAP running higher than you want, you can just dial down the infusion a bit. The half-life of norepinephrine and epinephrine is only a few minutes, so you'll find that the MAP starts drifting down pretty quickly. So, in most cases of distributive shock, you'll use fluids to fill the tank, and if that doesn't work, you'll use vasopressors to fix the pipes. An exception here might be anaphylaxis. If you figure out early on that the patient's shock is due to an allergic reaction, you can just give the usual epinephrine 0.5 milligrams as an IM dose, just as the patient would give themselves if they had an auto-injector. If 1 or 2 doses of IM epinephrine doesn't settle things down, then you can start some fluids and run the epinephrine as an IV infusion. One very important thing to highlight here, the dose of epinephrine when you give it IM is very different from the dose when you give it IV. Remember that 0.5 milligrams is like 500 micrograms, and you do not want to give 500 micrograms through an IV when the dose is supposed to be like 8. All right, now you know everything you need to know about distributive shock and vasopressors, so we can move on to the third type of shock, which is cardiogenic shock. This is a problem with the pump. The pump is weak or damaged or just not working right, and usually that means contractility is poor. The heart isn't strong enough to pump blood forward and fluid gets stuck in the pipes. Usually fluid collects in the veins, which causes swelling and congestion. Cardiogenic shock could also be a problem with heart rate. If an arrhythmia makes the heart beat too slowly, there wouldn't be enough blood circulating around. And if an arrhythmia makes the heart beat too fast, there won't be enough time for the heart to fill up. If cardiogenic shock is caused by an arrhythmia, the heart rate usually clues you in right away. And we'll talk more about that when we get to a module on arrhythmias. Otherwise, you'll find most of these patients look like someone in heart failure. They might have crackly lungs and shortness of breath from pulmonary edema, or they might have distended neck veins and swelling in their legs. POCUS can be really helpful here. You need a bit of training in this, but if you can get a good image of the heart, you can often just tell that it's weak from looking at it. If the heart rate is okay, and the problem is that the heart is weak or damaged, we've got to get this patient in front of a cardiologist who can put in a stent or repair a valve. To temporize things, we're going to treat with fluids and vasopressors again. Cardiogenic shock is one of the few types of shock where big boluses of fluid can actually make things worse. So we usually limit fluids to 500 mils or maybe a liter. The goal is to improve the heart's contractility, and we might be able to do that if we increase preload with a bit of saline. Remember that Frank-Starling curve. A little bit of fluid improves contractility, but give too much and you fall off the curve. We need to be careful because a weak heart can fall off the curve a lot sooner than a normal heart. So stay on top of those reassessments. If at any point you see signs of pulmonary edema, stop the fluids, move on to vasopressors. The preferred vasopressor here is probably norepinephrine. You'd think it would be epinephrine because all that beta activity should improve contractility, but a sick heart can be very prone to arrhythmias if it's overstimulated, and epinephrine is a lot of beta. Norepinephrine has a little bit of beta to help contractility, but not so much that it's going to make the heart beat faster or work much harder. Plus, the alpha stimulation squeezes down the pipes and probably helps venous blood return back to the heart. This can improve preload, which can also improve contractility. So, a little bit of fluid, a little bit of beta activity, we get the map up, and then we call a cardiologist to see if there's something they can do about fixing this broken pump. The final type of shock is obstructive shock, which occurs when something is blocking flow into or out of the heart. An example would be some kind of external force pressing down on the heart, like a tension pneumothorax or pericardial tamponade. That air or fluid squishes the heart, and usually the venous side collapses first. Blood can't get into the heart, and we have a preload problem. Obstructive shock can also happen if there's some kind of pulmonary embolism, where there's a blood clot sitting in the pulmonary veins. This is sometimes an afterload problem and sometimes a preload problem, depending on which part of the heart you're talking about. Remember that blood is supposed to flow from the right side of the heart through to the lungs. And if I block that blood flow with a big blood clot, I've just made an afterload problem for the right side of the heart. But it doesn't stop there. If blood flow to the lungs is blocked, there might not be much blood coming out of the lungs, and therefore the left side of the heart has a preload problem. Patients with an obstruction usually complain of chest pain and trouble breathing. And if you look for it, you might see those distended neck veins again. In someone with a pneumothorax, you might notice decreased breath sounds on one side of the chest, and in someone with tamponade, you might notice that the heart sounds are muffled or distant. Make sure that you look at the patient's legs. A blood clot in the lungs often starts out as a blood clot in the legs, so you might see that one leg is swollen or red. Point-of-care ultrasound is your friend in these cases. A pneumothorax usually looks like absent lung sliding, and a big pericardial effusion appears as a thick black band surrounding the heart. Obviously, you fix obstructive shock by alleviating the obstruction, and sometimes that's easier said than done. But one obstruction that you should be able to handle is a pneumothorax, because all that takes is a needle. If you think the patient has a pneumothorax, dig around in the crash cart and look for the biggest and longest IV that you can find. Feel around for the second intercostal space along the mid-clavicular line. Insert the needle and try to hit the rib so that you can walk your way just over it and avoid all of the blood vessels. When you feel a rush of air, slip off the catheter and pull the needle out. That's it. That's the whole procedure. You decompress the chest, save the patient's life, and somebody else can help you put in a chest tube later on if you don't know how to do that. But if the obstruction is a PE or tamponade, it gets more complicated. The treatment in these cases is going to be thrombolytics or a pericardiocentesis, and that kind of thing is going to take you some time to figure out. In these cases, we'll go to fluids and vasopressors again just to try and temporize things until we can get some help. In many of these cases, the problem is preload, so fluids are a good place to start. The hope is that fluid will stretch out the heart a little bit and counteract the compressive forces that are squishing it. The truth is, it's hard to overcome a compressive force with just saline, and if there's a really big obstruction producing a really high level of afterload, that fluid bolus might just collect in the veins and maybe precipitate heart failure. So this is another scenario where we usually limit fluids to maybe 500 mils or 1 liter, and then make an early jump to vasopressors. The ideal vasopressor here is not really well established, but most people think norepinephrine is the best choice. The alpha stimulation can increase systemic vascular resistance and help blood flow get to tissues without having too much of an effect on the heart or the lungs. Beta stimulation is probably helpful here, but excessive beta stimulation might make the heart and lungs work harder when they're already kind of stressed out. Let's summarize the approach. Tank, pipes, pump. If the tank is empty, you have hypovolemic shock. This is a patient that looks dry and dehydrated, and the treatment is to fill the tank with IV fluids or blood products. Give IV fluids in boluses of 500 mils or 1 liter and reassess after every bolus. If you have evidence that the patient is bleeding, you need to stop the IV fluids and give blood products. If the pipes are relaxed and dilated, you have distributive shock. This is usually a patient with an infection or an allergy. The treatment is first to fill the extra space with IV fluids. And if you hit the 2 liter mark without any improvement, you should probably start a vasopressor. Norepinephrine is an excellent choice. If you suspect an allergy, use epinephrine right away. If the pump is weak or damaged or just not working right, you have cardiogenic shock. This is usually a patient who looks like they're in heart failure. If there's an arrhythmia and the heart rate is too slow or too fast, we need to correct that. And if we can't fix the pump, a small bolus of fluids, maybe a maximum of 500 mils or 1 liter, might help things out. If you reach 1 liter, or if at any point you see signs of pulmonary edema, it's time to stop the fluids and start vasopressors. Norepinephrine, usually the best choice. If there's a blockage in the system somewhere, you have obstructive shock. This is usually a patient with chest pain and shortness of breath. We need to alleviate the obstruction, and if this is a pneumothorax, you can do that right away. If you can't unblock the system, use a small bolus of fluids, a max of 500 mils or 1 liter, and then try vasopressors. No one knows which vasopressor is the best, but norepinephrine is again a pretty good choice. Now, in most cases, you won't actually know what type of shock you're dealing with for at least the first couple of minutes. In these cases, the tank, pipes, and pump analogy can still help you organize your empiric treatments. First, fill the tank. Almost all forms of shock can benefit from some amount of fluid, so get a 500 ml bolus running right away. If the patient gets better, you can give a little more. When you assess and reassess, look for reasons not to give fluid. If you find evidence of pulmonary edema or bleeding, stop your fluids and change your strategy. Next, fix the pipes. Most forms of shock will get better before you hit that 2 liter mark. So if you've hit 2 liters of fluid and the blood pressure is still running low, it's time to switch to vasopressors. Norepinephrine is almost always a safe bet, and if you discover along the way that the patient has an allergy, you can switch over to epinephrine. Finally, remember to assess the pump and look for blockages. If the heart rate is super fast or super slow, look closely at that cardiac monitor. Maybe this is an arrhythmia and we need to fix that. Listen to the heart and lungs with your stethoscope, and if you can, examine the patient with POCUS. If you find a pneumothorax, get a needle and decompress the chest. And if you find some other kind of obstruction, you'll need help to deal with that, but you're already on the right track with the fluids and the norepinephrine that you've been giving. And there you have it. Now you know how to manage shock. So July 1st, you have the pager. You get the call, the patient's pale and sweaty and the blood pressure is low. Now you know what to do. When you're ready, take a look at our other videos so you can learn about respiratory distress, arrhythmias, and how to manage an altered level of consciousness. See you soon.